door to the ethmoid. For this, I have switched to 0-degree telescope again. I find my position. And one thing that you may wish to do is to try to never move both hands simultaneously. The recommendation is try to find a position with the endoscope, then freeze your hand that holds the endoscope and only manipulate with the other hand. Perfect. So, bring in your instrument and identify where it is you would like to resect the uncinate. I have mentioned there are many ways to do it, but let's do it the old-fashioned way. Try to palpate for the elasticity, and you see how the uncinate moves. It will not move in every specimen, but in most of them it will. When I do this, you may see that I use the blunt side of the instrument to avoid any lesion. Do not incise through the maxillary line, but go back a little further. Bulla, posterior margin of the uncinate, and the tip of my instrument is disappearing through the hiatus semilunaris. So choose 2 or 3 millimeters and just go through, but after 1 or 2 millimeters stop. Then turn your scalpel absolutely parallel to the lateral nasal wall. With this you avoid cutting in this direction, which may be intraorbitally already. So again, and whilst you are cutting, let's say inferiorly first, gently pull this away from the orbit, which you have hooked. So cut down. When you do this, make sure that you don't damage the inferior turbinate here. So you've gone through 3 layers, and now you start to look onto the inferior aspect of the bulla. Take out your instrument, rotate it, tip up, find the same spot without touching any of the other structures, and now you may go up superiorly. How far? Well, almost to the insertion of the turbinate, but don't quite go there. Don't cut into there. Leave it as is. And then find some information. And you see 3 layers. Mucosa, bone, mucosa, and here you're in the infundibulum. That leaves more uncinate to be resected, straight Blakesley. And now, depending on the instruments that you have, and I know you have all Blakesley, you may wish, can we clean it, to resect the uncinate inferiorly. Do not go here and pull. This is the beginning of disaster. Grasp either first inferiorly, but if you do so, you're on the left side now, don't rotate anti-clockwise, but in an alligator movement. And if you go for the superior attachment, now you could move in a clockwise session with a very short movement, and off comes that portion of the uncinate you have designed. Cottle, please. Now you can see that you have, my mistake, the lusk seeker. Now you still have uncinate process left, the lusk seeker. Lusk, the ballpoint seeker. There. Follow my finger. The ballpoint seeker. Yes. That's okay. So, you see, this is still there, but the recommendation is leave a little bit for the remainder of the procedure. You would wish to identify that at the end of your surgery, you may resect this, but it can be a very important landmark. If you would completely like to resect this, you can do now. Can I have the sickle again, please? Because now you're on the safe side. Oh, it's here. And you will not damage the mucosa in this area. That's a very frequent mistake, that people cause problems here. In reality, this would give you bleeding and a lot of trouble. So now you see exactly where the uncinate moves. and you can follow in the next stripe-wise resection to resect more of the uncinate in that very same technique. 3 layers that you can go through. But again, I will leave it because I would like to demonstrate at a later stage how to use this remnant over here. It looks easy. It is easy. The backbiter, and that's what you should try now, but backbiter to the right. Do not touch the middle turbinate. That should not be injured. Other side, please, to the right. Okay. Another option is, for conventional instruments now, to bring a backbiter behind, you see, and this would be an option now, and you see precisely that it is uncinate that you are removing. You are not going in and cut here. Always make sure that you only go behind the uncinate. But again, I will show that in more detail once we approach the maxilla, the natural ostium. You see those little foamy bubbles at 4 o'clock? This is where you will find the natural ostium. Back there is accessory ostium. Okay, go and get started. You have seen the natural ostium already, and you should have done so without touching or destroying the ethmoidal bulla, which may have been difficult in some of the specimen that you have to work on. Anyway, next step is now resection of the bulla. The safest place to do so is inferiorly and medially, furthest away from the orbital plane and away from skull base. So you go in here, but you would first like to see a lumen. Whether you do it with this instrument or any other is totally up to you. But make sure, stand up, Blakesley, make sure you see a lumen before you go on and take a hearty bite. And again, continuation may be with any instrument you wish. So I have made it a habit to go in, dilate this, and now I see the lumen, which in reality would be filled with pathology, what have you, straight through cutting, Blakesley. Now that is open and I need to remove the bulla. A variety of instruments are available. In that case, let me choose the through cut. And you see, whenever I go in with the blunt side of the instrument, I push aside the middle turbinate, but not fracturing it. Okay, but once you decide to open the bulla, make sure you open it completely and you resect it completely. This is a transition now to the horizontal part of the basal lamella, which I should not resect. Same instrument, upbiting. And now let's go for the superior aspect of the bulla. And I will demonstrate one more thing for you for the sake of time, so you can finish that before prayer time. Resecting superior aspect of the bulla. Okay. Carefully, the most dangerous area is of course if you go up and medially towards the lateral lamella of the cribriform plate, but this is standard anatomy that you all know. So most of the bulla is gone now. If we assume that the patient only has had disease in his or her, aspirator please, activate it, in his or her anterior ethmoid and the maxillary sinus, all you might need to do is just open the natural ostium of the maxillary sinus, the J curette, and stop the aspirator. Okay, now how, even with a 0-degree lens, to find the natural ostium? We here have an accessory ostium. We've seen that before. That's not the natural ostium. There is uncinate. This now would be the situation to resect more of the uncinate, and it will show you a variety of possibilities. Backbiter to the right. That would be a good idea for the shaver, but of course shaver is a very expensive thing and there is rarely a need for that instrument. Okay, but anyway, you could do it. You could do it with this old-fashioned instrument, the ostrom, but the important thing is not to go in here and look what happens to the patient's head. I can lift the head of the patient. Can you see that? That is definitely wrong, because now I would go through the nasolacrimal. Make sure that you can feel that you're just behind uncinate process, go up a little higher. That's one of the possibilities. See, you can nibble this away, and if you angle the instrument, you can even go down a little bit, but only take uncinate. Okay? Lusk seeker. Still with the 0 degree Lusk seeker. Still with 0 degree telescope. Now in that case we have the advantage of seeing the accessory ostium, but look what comes visible here now. Aspirator again. This is the natural ostium. And I will briefly switch to 30 degree to make that very well understood for you, because this is one of the most frequent mistakes of endoscopic sinus surgery, that people create what they call, I did a middle meatal antrostomy. That's all okay, but usually this does not connect the natural ostium. And look at this relationship now. Accessory ostium, which is non-functional. That brings air in too, but it will not bring any mucus out. This is the natural ostium. And look, aspirator, at its oblique position. And have a curved aspirator on it. But I think you see that now. Vertical, the natural ostium is tilted 15-20 degrees oblique, and you might go in there with one of the curved aspirators now. Okay, but I think this, and all mucus will come out here. If this is what you encounter, backbiter again, you should in any case connect the accessory with the natural ostium, which again can be done with a variety of instruments. Here it is easiest to go in with the backbiter, make sure you see the branch, and whoops, you can do that, but don't go too far anteriorly. In reality, this may be all you would have to do for chronic recurring maxillary sinusitis. That's one of the reasons. And now you have a marvelous view. You can even see the infraorbital nerve, etc., etc. Side biter. Side to right. And you can turn over the Heuwieser or the flamingo. If there is need for more opening, the side biter, as I have seen some of you using already, could be a very good instrument to do that, but take care not to bite down into the insertion of the inferior turbinate. So here we have a nice opening. We have created a connection between the accessory. Look, the mucosa is totally intact. The mucosa at the anterior circumferentia of the natural ostium is intact, so there is rarely a chance that this can totally stenose down. If now, the Heuwieser please, there is a need to do any manipulation, Heuwieser, the flamingo, first to the right then down. There is any need to go into the maxillary sinus, you can take this Heuwieser. This was, by the way, designed by a simple, in quotation marks, ENT doctor somewhere in Germany in the neck of the woods for post-op care of his patients. Ingenious instrument. And this is why it has the name of Heuwieser. You see, it goes around and it opens in a retrograde fashion. So you can reach all the way down, and if you take a 45 or 70 degree, you can use this and remove whatever you may need to remove. And now the one that goes down, which has this, that's the one that we've asked Storz to. It's not difficult to insert because you need to insert it like this. Upside down, bring it in, then change your grip. But with that, look now, you can go down to the floor, you can go anteriorly. Let me just rotate a bit so I can show you, even with a 30 degree, that you can reach the alveolar recess, etc. And that's a nice instrument to take care of cysts, etc. Okay, I think this what should be your next step. Identification of the bulla, further resection of the uncinate. Do not go for frontal recess yet. Do not go through the basal lamella, but expose the natural ostium and double check its relationship to the uncinate is always hidden behind. Should you have an accessory ostium in the posterior fontanelle, make sure you connect the two. Okay.